Hello, my name is Sarah Ford. This is University of New England Online's Biochemistry, or Chem 1005 course, the Unit 4 Case Connection presentation. Here we'll reflect on two cases that we might find clinically and use our knowledge that we've gained this semester to correlate. The first case in use involves a newborn girl who appears normal initially, but within the first day of life she develops lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. The panel of labs will include blood glucose, urinary acids, serum fatty acids, and plasma glutamine. Once the full blood workup is ordered, we can see the initial blood ammonia level is elevated and rises in fact further. The urine orotic acid level is also markedly elevated. The plasma citrulline level is within normal limits. The questions for this case: which diagnostic test would be able to distinguish best between a urea cycle disorder and a disorder in beta oxidation? Second, in this patient where orotic acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. The most efficient option for diagnostic tests to distinguish between fatty acid oxidation and urea cycle pathology is the plasma glutamine values. Analysis of plasma glutamine is helpful because plasma glutamine is elevated if there is a disorder within the urea cycle, but it would be within normal limits in a fatty acid oxidation disorder. In a disorder having to do with urea cycles, enzymes that degrade protein are generally deficient. The nitrogen accumulates as ammonia and will show as elevated ammonia in blood values. Before we answer the second question, let's revisit again the lab values. The initial blood ammonia is elevated and continues to rise. The urine orotic acid is also elevated, while plasma citrulline again is normal. Orotic acid is the optimal value to consider among the ordered blood work. The most common urea cycle disorder is called ornithine transcarbamylase deficiency. Carbamoyl phosphate builds up in the mitochondria where it is synthesized and spills into the cytosol, and it is used in pyrimidine synthesis, and an increase in orotic acid levels are in the urine. The enzyme least likely to be impaired is carbamyl phosphatase synthase 1. In this case, the rise in levels of orotic acid indicate that this patient does not have issue with the enzyme needed to create carbamyl phosphate, as the enzyme's role is to create carbamyl phosphate with the aid of ATP. This is a helpful slide to show the most common urea cycle disorder, ornithine transcarbamylase deficiency. We can see right here where the deficiency is, how that would affect the urea cycle downstream. Case number 3. A 47-year-old man is presenting to the ER with severe pain in his right great toe. He's not able to bear weight on his right foot, and there is no apparent trauma or injury. He reports that the pain started last night and continues to increase in severity. Based on physical exam and lab findings, he's diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. A question: what is the best explanation for the presentation of gout in this individual? Please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. The patient's lab values. The patient's plasma urate levels are 10.5. The normal values for plasma urate falls under 7 milligrams per 100 milliliters, so our patient's plasma urate is elevated. Our patient's urinary uric acid levels are 215. The normal values for urinary uric acid fall within the limits of 413 plus or minus 78, so our patient's urinary uric acid is decreased, well below the threshold of what is considered appropriate. Again, the question here: what is the best explanation for the presentation of gout in this individual? And please explain why other choices are not consistent with the data, or what additional information you may need to choose the root cause. Of the choices, overproduction of purines, decreased salvage of purines, or decreased urinary excretion of uric acid. In this scenario, decreased urinary output of the uric acid is the best explanation. If purines are overproduced, both plasma urate and urinary acid increase due to higher urate excretion rate. If we see a decreased salvage in urine, though urine output would be within normal limits, plasma urate would increase. After further discussion with our patient, he tells us that he switched recently from diet soda to regular soda because he read that the fake sugar diet soda was bad for him. He tells you he drinks between 4 and 5 liters of soda a day. What is the potential impact of this dietary modification on the presentation of gout? Well, our well-meaning patient decided to do some work on his diet in the hopes that his health might improve. He'd heard that artificial sweeteners were worse than regular soda, which elicited a change in his diet from diet sodas to regular soda with high fructose corn syrup. The patient has mentioned drinking 4 to 5 liters of soda daily, meaning that he is now ingesting a very high volume of high fructose corn syrup. Fructose is phosphorylated to fructose 1-phosphate, which decreases ATP while increasing AMP, which deaminates either to adenosine monophosphate or is dephosphorylated to adenosine. Both IMP, or adenosine monophosphate, and adenosine are used to produce uric acid, which we all know is now the cause of gout. These are my sources for this presentation. Thank you very much.